Welcome everyone. Today we are going to learn about neonatal sepsis and antibiotic therapy. So what are our specific learning objectives for today? Today we are going to basically learn about the definition and classification of neonatal sepsis, the risk factors and common etiology of neonatal sepsis, how to suspect a particular etiology or organism in a case of neonatal sepsis, what are the clinical features in brief, how to diagnose and confirm neonatal sepsis, what are the indications of sending blood culture, sending CSF analysis and administering antibiotic therapy, what are the principles of rational antibiotic uses in neonatal sepsis, and we'll compare the treatment, that is the empirical treatment and treatment in early and late neonatal sepsis, and what is the total duration of neonatal sepsis. So what is neonatal sepsis? Neonatal sepsis basically refers to sepsis in a neonate. So who is a neonate? Neonate refers to any baby whose age is between birth to 28 days of life, and sepsis refers to the clinical syndrome of dysregulated host response to infection in the bloodstream. So basically the presence of sepsis in a neonate is neonatal sepsis. So what is the relevance of neonatal sepsis? Why it is very important to learn about neonatal sepsis? Because it is the third leading cause of neonatal mortality after prematurity and birth asphyxia. So if we can learn to prevent and appropriately treat neonatal sepsis, then we can reduce the mortality of neonates significantly. The incidence is variable and depends upon multiple factors. Depending upon those factors, the incidence in a high income country can be as low as 1 to 12 per 1000 live births, but in a low and middle income country, especially ours like India, the incidence is as high as 38 per 1000 live births, or 4 babies in every 100 babies have neonatal sepsis. So coming to the classification. To learn about the classification, basically we need to remember about two time points. First time point is the birth, second is 72 hours. Any neonatal sepsis occurring between the birth and 72 hours, that means before the 72 hours of age, is classified as early onset neonatal sepsis, and any neonatal sepsis after that is called as late onset neonatal sepsis. Why this classification has been done? The classification has been done because the organisms isolated from the cases of early onset neonatal sepsis have been proven to be organisms that have been transmitted to the baby from their mothers. But the organisms transmitted or organisms isolated in the late onset neonatal sepsis have been seen to be community or hospital acquired organisms. So depending upon the etiological organisms, the classification has been done as early onset and late onset depending upon the cutoff point of 72 hours of life. So what are the risk factors? In the AIMS protocols for neonatology, these are the risk factors given. Basically, as we learned, the organisms seen in early onset neonatal sepsis have been acquired from the maternal genital tract. So all the risk factors of early onset neonatal sepsis are basically related to the maternal genital tract. So what are the risk factors? Prolonged labor, that is the combined duration of first and second stage of labor more than 24 hours, premature rupture of membrane, that is more than 24 hours, spontaneous preterm labor in absence of PROM, any foul smelling liquor which indicates presence of chorioamnitis or any abdominal tenderness, any single unclean vaginal examination or multiple clean vaginal examinations also, triple I, that is intrauterine infection and inflammation, that is triple I, and Apgar score of less than 4 at 1 minute of life. These are all risk factors for early onset neonatal sepsis. On the contrary, what are the risk factors for late onset neonatal sepsis? We just discussed in the previous slide that the organisms seen in the late onset neonatal sepsis are either community acquired or hospital acquired. So basically all the risk factors are related to that only, like community risk factors or hospital acquired risk factors. So what are those? Prematurity, low birth weight, history of ICU admission, history of mechanical ventilation, history of placement of invasive lines, history of administration of parenteral fluids, history of administration of stock solutions, poor hygienic practice, poor cord care, history of bottle feeding, and history of administering pre-lacteal feeds. These are all risk factors for late onset neonatal sepsis. So what are the common organisms isolated? Epidemiological data collected from our country reveals that almost in 22% of cases in which organisms have been isolated, the organism is Acinetobacter. That remains the most common organism overall currently in cases of neonatal sepsis. Other organisms are Klebsiella in 70%, 17%, E. coli in 14%, coagulase negative staphylococcus in 15%, staphylococcus aureus in 12%, and enterococcus in 6%. So these are six commonest organisms isolated from cases of neonatal sepsis, out of which Acinetobacter is the commonest, followed closely by coagulase negative staphylococcus aureus. So how do we suspect a particular organism in a patient of neonatal sepsis? Unless and until the organism is isolated from the blood culture, it is impossible to definitely confirm the presence of any organism in a case of neonatal sepsis. But some clinical pointers or some history can help us in suspecting the probable organism, which can guide us in administering the empirical antimicrobial therapy. For example, when do we suspect Klebsiella? Klebsiella in a patient can be suspected when the infection is hospital acquired and there is history of prolonged hospital stay or mechanical ventilation. Central venous catheter placement or previous antibiotic uses also increases the risk of Klebsiella infections. In addition to that, rapid onset and progression of a severe illness, presence of temperature instability, and presence of features suggestive of disseminated intravascular coagulation or DIC can also point towards the presence of Klebsiella infection. Similarly, when do we suspect Pseudomonas infection? Any history of prolonged hospitalization or invasive procedures, underlying or conditions like extreme prematurity, severe congenital anomalies, compromised immune system, basically anything that is compromising the immune system of the patient, presence of fever or hypothermia, presence of severe illness at presentation. That means patient is very sick right at the presentation itself. Presence of ecthyma gangrenosum, like you can see in this child, there is gangrene, multiple gangrenous spots on the limbs. Any lack of response to empirical antibiotics and presence of neutropenia are close pointers toward the probable presence of Pseudomonas in the baby. When do we suspect Staphylococcus aureus? Basically, like in any other, in any other case or like in any other children, presence of staphylococcal infection elsewhere on the body can help us suspect Staphylococcus in the neonate. For example, history of maternal infection or colonization with Staphylococcus aureus, any history of prolonged rupture of membrane, any maternal history of chorioamnionitis, premature or low birth weight babies, any skin and soft tissue infections, omphalitis, infected or inflamed IV catheter sites, musculoskeletal findings like osteomyelitis or septic arthritis, presence of shock, presence of diarrhea or signs of necrotizing enterocolitis. All these are caused by mainly by Staphylococcus aureus. So evidence of any of these findings in the baby can suggest a possible presence of Staphylococcus aureus as the cause of neonatal sepsis. Like you can see in this case, there is inflamed, swollen, red, tender joint. So this is a septic arthritis, and this is a omphalitis, that is infection around the umbilicus. When do we suspect coagulase negative staphylococcus? Presence of preterm baby or low birth weight baby, use of a central venous catheter, improper or inadequate aseptic measures before placement of an invasive line, which can lead to conditions like this, and a relatively milder clinical course can point towards the presence of coagulase negative staphylococcus. E. coli is the most common organism causing urinary tract infections. So any history of maternal urinary tract infections or prolonged rupture of membranes can point towards presence of E. coli. History of intrauterine growth retardation, feeding intolerance, lethargy or hypotonia, like has been demonstrated in this picture, can point towards the possible presence of E. coli in the baby. When do we suspect Acinetobacter? If we have a known outbreak or high prevalence of Acinetobacter in the neonatal ICUs, just like we are seeing recently that in most of the neonatal ICUs in the country and all over the world, more and more isolation of organisms have been revealing Acinetobacter infections. So if in a particular neonatal ICU or in a particular hospital setup, it has been seen that most of the organisms isolated are Acinetobacter only, then we have to suspect Acinetobacter in that setup because it is probably hospital acquired. So prolonged hospitalization, prior antibiotic use, presence of ventilator associated pneumonia, Skin and soft tissue infections and improperly sterilized ICU equipments can lead to Acinetobacter infection in a neonate, causing neonatal sepsis. And lastly, when do we suspect enterococcus? Enterococcus is suspected when there is history of maternal colonization or intrapartum fever, prematurity, indwelling devices like central venous catheter, like you can see in this case, there is a femoral line has been placed, and unexplained metabolic acidosis in a baby can suspect or can guide us or can lead us to suspect presence of enterococcus in a neonate. So what are the clinical features in a neonatal sepsis? There is no point telling about the clinical features in a neonatal sepsis case because as you can see in this slide, any clinical feature in a neonate can be feature of neonatal sepsis. It can be a non-specific sign like hypothermia, poor suck, lethargy, hypoglycemia and hyperglycemia, or it can be ascribed to a particular system like central nervous system, cardiovascular system, gastrointestinal system, respiratory, renal, hematological and dermatological system. And the clinical features can be variable. Basically anything and everything can be caused by or can be a feature of neonatal sepsis. So when a particular clinical feature that can be in the history or that can be in the clinical examination finding that cannot be ascribed to any other pathology, always neonatal sepsis should be kept in mind. So how do we diagnose neonatal sepsis? There are various modalities to diagnose neonatal sepsis. These are the common modalities that are available to us to diagnose neonatal sepsis. We'll go by them one by one. First and the most gold standard is the blood culture. So it must be performed in all neonates suspected to have sepsis. A common confusion arises that when to send blood culture in a suspected case of neonatal sepsis. The answer is always. Whenever we are suspecting neonatal sepsis, we have to send blood culture because it is the only gold standard available, and that is a 100% confirmatory investigation that can confirm the presence of neonatal sepsis in a child. So best guide, it is the best guide for deciding upon the choice of regimen for antimicrobial therapy, especially when the baby is not improving to our empirical treatment. Important point to remember is that for adequate yield, 1 ml of blood for 5 to 10 ml of culture broth must be sent. For example, if this is a culture bottle and this contains 30 ml of culture broth, we have to send at least 3 to 6 ml of blood in it. That means 1 ml for every 5 to 10 ml of culture broth. This will ensure the adequate yield of the organism, because if we send inadequate samples, the growth will not happen and we will miss the case of neonatal sepsis. Recently, there are backtech and bactalert systems available which can give results very quickly and help in our treatment of neonatal sepsis. Second most important is sepsis screen. What are the components of sepsis screen? There are 5 components of sepsis screen. First is total leukocyte count. Second is absolute neutrophil count. Third is immature to total neutrophil ratio. Fourth is micro erythrocyte sedimentation rate or micro ESR. And fifth is C-reactive protein or CRP. The absolute neutrophil count is a age specific value which can be known for a term child from the Monro's chart and for a preterm child in the Mogino's chart. Important to note is that more than or equal to 2 abnormal parameters of these 5 must be present to call it a positive sepsis screen. That means if out of these 5 any 2 are present, then we can call it a positive sepsis screen. Very important point to know in that the sepsis screen has high sensitivity and low specificity and low positive predictive value and high negative predictive value. What does it mean basically? This basically means that sepsis screen can be used with higher reliability to rule out sepsis rather than rule in sepsis. So what does that mean? In further simpler terms, we can tell that if sepsis screen is positive in a baby, we cannot 100% tell that the baby is having sepsis definitely. But if sepsis screen is negative in a baby, we can 100% tell that the baby is not having sepsis. So that is the meaning of this sentence. Next, there are some newer biomarkers like serum procalcitonin, serum amyloid A, hepcidin, CD64, CD11B, interleukin 168, TNF alpha, soluble TNF receptor, E-selectin, and ICAM. These are the newer biomarkers which are under research as a role for diagnosis in neonatal sepsis, but these are not widely available. So, as of now, these cannot be used reliably to diagnose neonatal sepsis. Molecular assays can be used as the method of hybridization and amplification of pathogen DNA. For example, like PCR, it is considered as an add-on test, not the only test, but it doesn't give any information on the antibiotic sensitivity. It only tells the isolated organism. It has high cost and very poor lack of availability in the peripheral setups. So this has limited role in the diagnosis of neonatal sepsis. Urine culture. When to send urine culture? There are definite indications of sending urine culture, but basically we can remember that whenever we are suspecting presence of urinary tract infection, we should send urine culture. So what are those conditions in which we suspect urinary tract infection? First is when the baby is at risk for fungal sepsis, for example, like an immunocompromised child. Second is presence of urogenital malformations like posterior urethral valve or ureterocele or any urogenital malformation like that. Third is presence of vesico-ureteric reflux, which can be easily known by a point of care ultrasound machine. And any other scenario when we are suspecting urinary tract infection. For example, the baby is crying during micturition and becoming silent or calm after the urination is complete. So in those particular scenarios, we can suspect urinary tract infection, and to confirm that, we have to send urine culture. So what are the methods of collection? There can be various methods of collection of urine sample in urinary tract infection, but the most definitive and preferred one is suprapubic puncture, because if we follow appropriate aseptic measures, this is the most sterile sample available, and any growth from this sample is confirmatory for presence of urinary tract infection. But other methods can also be undertaken, like bladder catheterization and clean catch midstream sample. Radiology. Basically, radiology can be undertaken for any site like a chest X-ray, abdominal X-ray, or transcranial ultrasound or CT scan. So, all those radiological investigations should be undertaken when there is definite indication pertaining to that site. For example, if a baby is having recurrent apnea or if a baby is having respiratory distress, we have to look for a pathology in the chest and we have to send chest x-ray for that. Second is when the baby is having abdominal distension, vomiting, feeding intolerance, redness around the umbilicus, anything like that. So we are suspecting a pathology in the abdomen, so we can do an abdominal x-ray. Third is whenever we are suspecting enlarging head size, sudden drop in hemoglobin and sudden appearance of pallor, bulging fontanelle, disappearance of pulsation of the fontanelle, anything like that. So basically we are suspecting an infection in the central nervous system. So to confirm that, we can undertake neuroimaging to confirm intracranial abscess, ventriculitis, hydrocephalus, intraventricular hemorrhage, etc. And last but not the least is CSF analysis. In all cases of suspected or confirmed sepsis, we have to undertake CSF analysis. The question is that, or the confusion is that, in which cases of neonatal sepsis we do a CSF analysis. The answer is always, except there is only one scenario. If antibiotics have been started solely on the basis of risk factor in asymptomatic neonates, then we need not perform CSF analysis. We'll take up this discussion again. Next is which guidelines to follow or which cutoff to use, because as we know, in adults and older children, presence of a single polymorph indicates meningitis, more than 5 cells indicates meningitis, but in neonates the cutoffs or the normal values are slightly different. So to know that, we have to follow the NNF clinical practice guidelines or NNF CPG. So what are the NNF clinical practice guidelines? They have been released in 2021. It recommends that we have to use CSF protein and WBCT count for diagnosis in neonatal sepsis. We should not use CSF glucose in neonatal sepsis evaluation. As we know from the adults and child guidelines, the protein, glucose and WBC count, all three parameters are taken together while considering the presence of meningitis in a child. But in neonates, according to the NNF-CPG, glucose need not be taken, only protein and WBC. So what are the normal range or reference range in a neonate? There can be various parameters, reference range of lymphocytes, glucose, etc. But as we just learned, we need to consider only these three things, that is WBC count, second is presence of polymorphs, third is protein. Only these three things we have to consider. These are the normal values. If any time this normal value is exceeded, then we have to consider the possibility of a neonatal sepsis, especially meningitis. So what are the various groups of patients possible in a case of neonatal sepsis? As we learned, there can be a larger group in which risk factors are present but symptoms are absent. There can be a smaller group among that in which symptoms are also present. There can be a further smaller group among that in which the sepsis screen is present. There can be a further smaller group among that in which culture is present. That means these are the four groups of patients that can be present in among the population of suspected neonatal sepsis. First group is in which only risk factors are there. Second group is in which symptoms are also present. Third group is in which sepsis screen is also positive, and fourth is a smaller group of patients in which culture has also revealed some organism. So these are the four groups of patients. So in which group of patient you have to send blood culture? Answer is all. All neonates suspected to have sepsis, blood culture must be sent. That means if sepsis screen is present, blood culture must be sent also. If symptoms of neonatal sepsis are present, blood culture must be sent also. If risk factors are present also, then also blood culture must be sent. Indications of starting antibiotics. When do we start antibiotics? The answer is in whichever baby you suspect neonatal sepsis, you start antibiotic in that baby. So basically in all the cases, as we discussed in the previous slide also, you have to start antibiotics. But the important point to remember is that ideally blood culture must be sent before starting first dose of antibiotics. So if we are planning to start antibiotics in a baby in view of suspected neonatal sepsis, always make sure that the blood culture is collected before administering the first dose of antibiotics, because administering a single dose of antibiotic also decreases the yield significantly of blood culture. Third, most important question and most confusing scenario that the residents face. When do we do CSF study in a baby? So basically all neonates suspected to have sepsis, we have to do CSF study. Only one exception. We discussed three groups or four groups of patients before. Basically we have to do CSF study in all. Only one group of babies we do not need to do CSF study. That is, if a baby doesn't have any symptoms, and only on the basis of risk factors we are suspecting neonatal sepsis. For example, the baby doesn't have poor feeding, lethargy, hypoglycemia, respiratory distress, convulsion, anything, but the baby has come because only foul smelling liquor was there. There was history of foul smelling liquor, so there was one risk factor present, but the baby is completely asymptomatic. The sepsis screen is also negative, the blood culture is also negative, showing no growth. So in that case we do not need to do CSF study. For example, if a baby comes to you with respiratory distress, so in that case, irrespective of the presence or absence of risk factor, there is a symptom present which can be ascribed to neonatal sepsis. So we have to do CSF study in that baby in spite of the baby just having respiratory distress. So what is the treatment of neonatal sepsis? Basically, five modalities of treatment are available to us. We'll discuss that one by one. First and most important is supportive therapy. The baby always has to be nursed in a thermoneutral environment. The respiratory support has to be administered appropriately so as to maintain normoxia, and we have to ventilate the baby if needed. We have to administer parenteral fluids if there is any contraindication to oral feeding or the baby is not able to feed orally, and we have to maintain normoglycemia, that is glucose in the normal range. And if the baby is having anemia, then we have to administer or transfuse packed red blood cells. The second and definitive treatment of neonatal sepsis is antimicrobial therapy or antibiotic therapy. So when do we administer antibiotic? Simple answer is that we have discussed before. Whenever we are suspecting neonatal sepsis, we have to administer antibiotic therapy. There is no treatment of neonatal sepsis without antibiotic therapy. So whenever there are more than equal to three risk factors, whenever there is suspected or confirmed intrauterine infection or inflammation, that is triple I, whenever there are two or more risk factors plus sepsis screen positive, or whenever there is strong clinical suspicion. So basically any scenario which suspects or which leads us to suspect neonatal sepsis, we have to administer antibiotic. There is no use of prophylactic antibiotic therapy. That means if a baby doesn't have any risk factors, doesn't have any clinical findings, doesn't have any investigation suggesting sepsis, we just cannot administer antibiotic therapy so as to prevent sepsis. There is antibiotic therapy only for treatment of neonatal sepsis, not for prevention. Next is exchange transfusion. What does exchange transfusion do? Basically, it removes the inflammatory cytokines and bacterial products. It leads to 50% reduction in sepsis related mortality, and it can be especially useful in cases of scleroderma and multi-organ failure. So if a particular patient suspected to be having neonatal sepsis is not responding to our conventional antibiotic therapy, and or there is presence of scleroderma or multi-organ failure, then we can consider exchange transfusion as a modality of treatment. Fourth is immunotherapy. There is availability of IgG, IgM enriched IgG and various colony stimulating factors, but they do not have any proven benefit. Some small studies have been done which have revealed some benefit in the cases of neonatal sepsis. So this is a scope for research and further studies. Lactoferrin has a therapeutic role that has been proven in some studies, especially in preterm infants with necrotizing enterocolitis. So what is the choice of antibiotics? First, when the baby is coming to us and we are suspecting a neonatal sepsis, we have to send the blood culture before starting antibiotics, and we have to start empirical antibiotic therapy. The thing about empirical antibiotic therapy is there is no absolute rule of thumb. For example, there is no guideline that you have to start injection ampicillin and injection gentamicin for a case of neonatal sepsis. There is nothing like that. The empirical antibiotic therapy has to be unit specific. What does it mean? That means in your particular field or in your particular unit or in your particular hospital, depending upon the review of various culture reports that were available to you in the last 3 to 6 months, you have to see that which is the most common organism isolated from all the cases of early onset neonatal sepsis and which is the antibiotic coming sensitive to most of those organisms. Depending upon that, you have to formulate a unit specific protocol which will be which you will be using while deciding upon the empirical antibiotic therapy for a suspected case of neonatal sepsis. So this has to depend on the prevalent spectrum of organisms and their sensitivity patterns. It can be modified according to the sensitivity patterns once culture reports are available and depending upon improvement of clinical condition of a unit. For example, a unit has come to you in which you are suspecting neonatal sepsis. So depending upon your unit specific guidelines, suppose you have started injection cefotaxime and injection amikacin as the treatment for the neonatal sepsis. You have sent the culture also before sending the antibiotic therapy, before starting the antibiotic therapy. Now 4 days later, the culture report reveals coagulase negative staphylococcus sensitive to cloxacillin, suppose. So now you will see whether your empirical antibiotic therapy has been successful in causing the clinical improvement of the baby or the baby has not improved significantly. If the baby has improved significantly, then most probably you will decide to continue that antibiotic therapy rather than changing it. But if your baby has not improved significantly as much as he or she would have improved, then you have to consider the culture report and the sensitive antibiotics, and you have to change the antibiotics or upgrade the antibiotics depending upon your protocol. But in some particular settings, there is some guidelines regarding which antibiotics you can choose as the empirical treatment. This is not a rule of thumb, but this is a general guideline. So in community acquired cases, you can safely start with injection ampicillin and injection gentamicin. In a hospital acquired setting, you have to consider starting beta lactam antibiotics plus or minus aminoglycosides. But if you are suspecting meningitis in a particular baby, like by the presence of bulging fontanelle or presence of convulsion or presence of poor feeding, lethargy or anything like that, you have to definitely start a third generation cephalosporin, most likely a injection cefotaxime. But are there any particular scenarios in which you can use a definite antibiotic? We already discussed that in which scenario you can suspect a particular organism. For example, we were suspecting staphylococcus in which there was history of omphalitis or cellulitis or septic arthritis. So if it is there, then you can safely use a anti-staphylococcal antibiotic which is cloxacillin. Similarly, if you are suspecting MRSA, that is methicillin resistant staphylococcus aureus, it is safe to assume that you have to use vancomycin as your empirical treatment. Next, if you are suspecting pseudomonas, then you have to use antibiotics with anti-pseudomonal activity. For example, piperacillin plus tazobactam and amikacin. Similarly, when you are suspecting a multi-drug resistant gram-negative organism, you have to definitely administer ciprofloxacin. When you are suspecting enterococcus, like in those patients in which indwelling catheter was there, maternal infection was there, in those scenarios, you can use ampicillin and gentamicin as your empirical therapy. And suppose if you have revealed resistant enterococcus, then rather you have to use vancomycin. So this is a overall guideline that whenever you are suspecting a particular organism, you can use these antibiotics. But while administering antibiotic, you have to you remember these useful points for sticking to rational antibiotic uses. So what are those? We have to use always strict indications for antibiotic use. Antibiotics only have to be used when clear evidence of infection or strong clinical suspicion is there based on symptoms and lab findings. You cannot use just antibiotics according to your whim or as a prophylactic measure. Antibiotics always have to be administered as a treatment measure for neonatal sepsis. Always use culture sensitivity tests to obtain appropriate culture before starting antibiotics. This I have already emphasized before. Always review and de-escalate. Based on the culture reports and clinical progress, discontinue if the infection is ruled out. For example, you are suspecting methicillin resistant staphylococcus aureus in a particular baby, so you have started injection vancomycin as your empirical treatment. But 3 days later, when you get the culture report, you see that methicillin sensitive staphylococcus aureus is there, so you will de-escalate, you will stop the injection vancomycin and rather you will use injection cloxacillin, which is the drug of choice for that. So always review and de-escalate. Always a higher antibiotic is not always a better antibiotic. Fourth is you have to develop an antibiotic stewardship program in your hospital, and we have to implement and adhere to it based on the individualized protocols. You have to always educate and train not only yourself but other healthcare personnel also who are involved in the treatment of neonatal sepsis, like the education and training you are going on right now by watching this video. Next is duration of therapy. You have to follow evidence based guidelines that will come again in the next slide. Next is empirical therapy guidelines. Develop and use local guidelines based on local antibiogram, just like I told that how you develop an empirical antibiotic therapy for your unit. Next is avoid broad spectrum antibiotics. Always avoid broad spectrum antibiotics because those have to be reserved for specific cases where they are absolutely necessary. You should not use a broad spectrum antibiotic as an empirical therapy. Next, you have to monitor side effects. Among the groups of drugs available, antibiotics are a very high risk drugs. So always whenever antibiotic therapy is needed in a neonate, it will be needed for either 5 days, 7 days, 14 days or 21 days, like that. So it is a prolonged treatment. So any therapy that we are taking for a prolonged duration of time is expected to have some side effects. So we have to monitor the babies for their side effects. Last is parental involvement. We have to always educate and involve the parents in the decision making process. So what is antibiotic stewardship? This is a lecture in itself, but I will just highlight 5 or 6 important points. Always we have to downgrade to a narrower spectrum or less costly antibiotic to which the organism is sensitive, irrespective of the clinical response, like the scenario we discussed just now. Always, except pseudomonas, single sensitive antibiotic is enough for almost all. So always try to use single antibiotic. Only in case of pseudomonas we have to use multiple antibiotics starting from the right from the start. Just like we discussed, we have to start piperacillin tazobactam plus amikacin when we are suspecting pseudomonas in a baby. Next is multi-drug resistant organisms with intermittent sensitivity to more than equal to one antibiotics. We have to consider higher dose of antibiotic with or without in combination. We can use various web-based early onset sepsis calculator. I'll show you an example in the next slide. We have to review the regimen, that is the empirical therapy regimen, every 6 to 12 months by reviewing our antibiograms or antibiotic sensitivity reports or culture reports. Cephalosporins are never the first choice in a neonatal sepsis because rampant use of cephalosporins as the first choice antibiotic can induce extended spectrum beta lactamases, which can give rise to multi-drug resistant organisms in the future. And we have to always reserve the antibiotics as per the AWARE classification by the WHO. What is the AWARE classification? Basically, World Health Organization classifies all the antibiotics available in the world into basically 3 groups. First is access group, second is watch group, third is reserve group. What is the access group? Access group refers to the essential antibiotics that should be widely available. For example, amoxicillin and clavulanate. Watch group refers to antibiotics with higher potential for resistance and should be used very cautiously. For example, levofloxacin. Always, while administering empirical therapy, we have to avoid this watch group and reserve group of antibiotics and try to give an antibiotic from the access group. Last is reserve group. Reserve group of antibiotics are reserved for treating infection caused by multi-drug resistant organisms, and those should always be reserved for last scenario, last resort. They should not be used right from the start. Those include meropenem, aztreonam, linezolid, and some other antibiotics. So as you can see here, the World Health Organization gives 3 lists of antibiotics in a single spreadsheet or Excel sheet. There are access groups, watch group, and reserve group. How to download this protocol or how to download this list of antibiotics, I will give the link in the description. And this is the book by WHO, the WHO aware book, access watch reserve antibiotic book. Everyone is requested or everyone should read this book for ensuring appropriate antimicrobial therapy. This is the sepsis calculator I was talking about, where there are various web-based calculators. Any of them you can use, in which you can input some parameters depending upon the history and clinical feature of the patient, and the calculator will give you an estimated risk of sepsis in that baby. Depending upon that, you can use your unit specific guidelines, that if the risk is beyond this percent, we can use or we can start empirical antimicrobial therapy. So what is the evidence? Evidence says that out of all the babies getting antibiotic therapy, almost 69% of the babies get ampicillin, 58% get gentamicin, 18% get cefotaxime, and 10% get vancomycin. So this 10% is also a significantly higher number. So we have to adopt a rational use of antibiotic in all the cases, so that these significantly higher percentage of antibiotic use can be reduced to as low and as appropriate levels as possible. So how to choose antibiotics between early and late onset sepsis? It has been seen that in most of the cases of early onset sepsis, the most common organism isolated is E. coli followed by group B streptococcus, and in most of the cases of late onset sepsis, the most common organism isolated is coagulase negative staphylococcus, E. coli, enterococcus, staphylococcus, etc. So whenever choosing an antibiotic therapy, we have to choose an antibiotic therapy that is appropriate for covering these organisms without need for choosing an antibiotic from the watch or reserve group. We have to always use antibiotics from the aware group. So unconfirmed cases or empirical therapy, mostly it has been seen that if you use ampicillin and gentamicin, then it will cover most of the organisms, and after confirmation, if sensitive, you can change to cefotaxime. Similarly, in the late onset cases, in this study it has been seen that most of the babies got vancomycin and gentamicin as the empirical treatment, and after confirmation they needed to be changed to gentamicin and rifampin depending upon the sensitivity reports. So you can use a similar unit specific protocol, or you can prepare a unit specific protocol by reviewing your antibiotic sensitivity reports of last 6 to 12 months, and you prepare a unit specific guideline like this. So what is the duration of antibiotic administration? In cases where only clinical suspicion is there or risk factor and sepsis screen are present positive, then you can use the antibiotic for 7 days. But if the blood culture is positive and isolating some organism, you have to at least administer the antibiotic for 14 days. But if the CSF is also positive, that means there is meningitis, you have to at least administer the antibiotic for 21 days. In specific scenarios like abscess or septic arthritis, the duration of antibiotic therapy may need to be prolonged to as high as 4 to 6 weeks also. So what is the take home message that we learned today? First thing is, early recognition and diagnosis of neonatal sepsis is very important, and we have to utilize appropriate diagnostic tools and laboratory tests for that. It is very important to maintain an appropriate rapport with the Department of Microbiology and Pathology, so that they can help us in choosing an appropriate antibiotic therapy. Second is rational antibiotic use. We have to always have justification for starting empirical antibiotic therapy in suspected cases, and we have to have a definite criteria for choosing initial antibiotics based on the local resistant patterns. Third is, we have to develop antibiotic stewardship principles, which is important for appropriate antibiotic selection, dosing, and duration, and we have to implement those strategies to minimize the overuse and misuse of antibiotics. We have to always consider de-escalation, and we have to always administer the antibiotics for the appropriate duration based upon certain guidelines and recommendations that are easily available. We have to always encourage the various prevention strategies, so that which can highlight the measures to prevent neonatal sepsis, such as infection control practices and maternal health optimization. We have to take up a multidisciplinary approach in which we can collaborate between neonatologists, pediatricians, microbiologists, and pharmacists in managing the cases of neonatal sepsis. We have to always monitor and report if any adverse events are happening. We have to always educate and train the various healthcare providers who are involved in the treatment of neonatal sepsis or care of the babies affected with neonatal sepsis. Always we have to encourage family involvement. We have to educate and involve the parents in the decision making process. And future directions, like we have to stay updated on the emerging research and advancements in management of neonatal sepsis, and we have to promote research on the new diagnostic methods, treatments, and prevention strategies. So I hope everyone learned a lot today. Feel free to like this video if you learned anything new from this video. Share this video with your friends who are interested in managing neonatal sepsis, and subscribe to the channel. Thank you.